Bonjour, je suis désolée, on va parler en anglais parce que je ne parle pas le français bien. Today I'm going to talk about lymphoproliferation as a presentation of primary immune deficiency at St. James University experience. The main objective of this talk is to see how the collaboration between the main aim of my presentation is to see how the collaboration between the oncologist and raising the awareness about having the immune deficiency between oncologists helped us to diagnose patients who were really moving in the in our community and they were not diagnosed. So I'm going to talk first about what is lymphoproliferation in immune deficiency. It refers to persistent polyclonal, oligoclonal, or monoclonal proliferation of lymphoid cells in the clinical settings of having an underlying inborn errors of immunity. The incidence is quite rangeable. It ranges from 0.7 to 18%. And having a lymphoproliferation is not only a risk of having a malignancy later on, but it's sometimes these patients they do have an association of having an underlying HLH. So this makes the diagnosis really challenging as there is no really a pure guidelines on the diagnosis and management of these cases. So what are the clinical clues? Unfortunately, there is no clear guidelines or clean clinical clues that can differentiate if you have a patient with a benign lymphoproliferation, if he will have an underlying immune deficiency, except for the age. The younger age really should be considered as a risk factor or an alerting sign that I should go deep and see if there is an underlying immune deficiency in such patient or not. Coming to the diagnosis, the diagnosis is done through histopathology assessment, flow cytometry, and then molecular assay. So histopathology is really tricky because it's correlating with the underlying immune deficiency, and the pathologist should be very meticulous in his diagnosis because there are pitfalls that make them diagnose these patients, unfortunately, of having lymphoma, but they turn out to be, and they start chemotherapy, but they don't have actually lymphoma. And we had a couple of patients who went through this path and they got chemotoxicity from the chemotherapy, and they turned out not to having lymphoma. And also in the histopathology, it's very important to look for the EBV because EBV is one of the most important triggers for the lymphoproliferation in such group of patients. And when you look at the pathology, be aware that sometimes the EBV causes downregulations of the CD20, 19, and 79B and upregulates the 30, which mimics a lot lymphoma pathology. Coming to the next diagnostic tool is the flow cytometric assessment, which we use it to detect the presence of EBV and to do the lymphocyte subsets, whether for the T and B, memory and naive B cells and others. Finally, we do the molecular assay that includes the southern blot hybridization, PCR, and the most important is the next generation sequencing. What about the treatment? Treatment is there is no clear treatment for these patients. It depends on what is the underlying pathology or the disease that you have. You should go for the supportive therapy is IVIG, prophylactic antibiotic. Look every now and then for complication, for development of HLH, for development of malignancy. And then based on this, you treat. Whether you do a transplant, you give a chemotherapy, you give anti-CD20, it depends. After I have talked about the lymphoproliferation, I will move to our center experience in Ain Shams University. So in Ain Shams University, we have a collaboration as I'm a consultant in the biggest children cancer hospital in the Middle East, which is 57357. Oncologists there have detected patients coming as query having lymphoma, but they turned out after doing the pathology and the test that they don't have lymphoma. They referred them to me for diagnosing of what is the cause of such lymphoproliferation. So we had 21 patients coming with lymphoproliferation. They were recruited from the period of 2018 to 2020. They were 12 males and 9 females. The reason for the referral to the Children's Cancer Hospital was suspecting having lymphoma. As for the 10 warning signs, none of them had any of the 10 warning signs, except for 11 out of the 21 had history of repeated minor infection. None of them necessitated hospitalization. Our patient had a median age of presentation at 30 months, And then age of presentation at the oncologist at the Children's Cancer Hospital was 48 months. Age of diagnosis of having an underlying immune deficiency was 72. The diagnostic lag between the presentation and the final diagnosis, we had a median of 24 months. Only 4 patients had failure to thrive. 100% of them had organomegaly and lymphadenopathy. 7 out of the 21 had HLH features. As for the laboratory test, normal cellular bone marrow was found in 17 out of the 21. Lymph node biopsy showed hyperactive non-specific lymphoproliferation as the biopsy. Viral infection by ABB was present in 3 out of the 21. 10 patients had cytopenias. 8 patients had low immunoglobulins. 10 patients had an abnormal lymphocyte subset, and 2 had an elevated double negative T cell. We were able to do genetic sequencing for 17 out of the 21 patients. As regard the past history of immune dysregulation, we had 8 patients out of the 21 having history of either cytopenias, autoimmune hemolytic anemias, something like that. Family history of a SIB death or a SIB who had a similar condition and was not diagnosed was present in 6 patients. 15 of them are alive till now, and we successfully transplanted 3 patients. As for the genetic sequencing, with the patients who we were able to do for them genetic sequence, familial HLH had the largest number. We had 6 patients who had had HLH. They were either perforin or UNC13. Most of them had an UNC13 mutation, and 1 patient, unfortunately, we couldn't do for them genetics. As for the combined immune deficiency, we had a patient with a JAK3, 1 of the IKKB, and 1 with the Wiskott-Aldrich. We had 1 patient with a common variable immune deficiency, 2 patients with ADA2, 2 patients with an RBA mutation, 2 SIBs with a FAS mutation, and 1 patient who had a chronic granulomatous disease, and 1 patient who had COT9, and another patient who had the RAS GRP1 gene. This patient was successfully transplanted. And 2 patients with a one patient with a TTC7A and another with a STAT5B, and this also patient was successfully transplanted. I'm going here to present because I found them very interesting to see the spectrum of the ADA2, how our 2 patients had a completely different presentation. For the history of recurrent infection, patient number 1 didn't have any infections, but the second patient had recurrent infections. History of previous autoimmune cytopenias or organomegaly, it was negative in both patients. Family history was present in patient number 1. She had a SIB who died with a similar condition undiagnosed. At the other patient, he had no similar condition in the family. Both of them has a generalized lymphadenopathy and hepatosplenomegaly, but patient 2 who had recurrent infection had a 3rd-degree clubbing in his finger. As for the laboratory test, the first patient who didn't have history of infection, she had a normal lymphocyte subset and normal immunoglobulins, whereas the second patient had a low CD19 and low immunoglobulins. As for the genetics, both of them showed an ADA2. Unfortunately, the first patient died. The second one, he's alive, but the parents refused to go for a transplant. So from these patients, we see that ADA2 could come with an immune dysregulatory feature, or it comes with recurrent infection. Then later on, they could develop an immune dysregulatory feature, which was really interesting in these patients. And this takes me to my take-home message. It's very challenging to differentiate between the benign and the malignant lymphoproliferation. It really needs an expert experience. In patients with inborn errors, benign reactive lymphoproliferation must be thoroughly investigated and monitored because of their possibility of having malignant transformation later on. We should do for them EBV testing not only at the beginning, but we should do a follow-up every now and then for EBV testing. Genetics and flow cytometry is very important to help us in the diagnosis. And we need to develop a team of immunologists, pathologists, and oncologists to help reach the diagnosis for these patients and build a great experience. And always suspicion is the key for such cases. And I would like to thank Dr. Raif Jiha in Boston Children's Hospital and his team, and Dr. Sophie Hamilton in UK at the Great North Children's Hospital, because they helped us in doing the genetics, and my PI team in Ain Shams University, and finally my dearest professor, Dr. Shireen Rida. Thank you so much.